Welcome everyone to this week's clinical case. This is a challenging tooth, and obviously there's a questionable prognosis associated with the tooth in the way of a crack. So this is a case of a lower right 6. The patient, it was external referral from another clinician, and the tooth was having symptoms that indicated irreversible pulpitis. And when we look at the pre-op radiograph here, you can see clearly on the mesial root that there is apical inflammation. And then coronally, we have quite a large filling, and there's a possibility that this large filling is encroaching on one of the pulpal horns. But when we opened up the tooth, we can obviously see a crack. And what I'm going to do throughout the video, we're going to talk about this. But to put it very, very succinctly and clearly, traditionally, maybe 20 years ago, 10 years ago, a tooth which had a significant crack like this, arguably would have been removed. A lot of people would say this tooth's out. But I think now we're starting to move away from removing teeth straight away. And I suppose in my book, if a tooth is cracked, but the crack doesn't extend through and through, so in this case, there's a crack mesially, there's a crack distally, and also there's a crack buccally. As long as the crack doesn't reach along the pulpal floor, in my book, I think the tooth is still savable. And also if the crack doesn't extend into a canal orifice again, I think the tooth is savable. That's not to say that during the consenting process, the patient needs to be made well aware of the significant reduction in prognosis with this tooth, but the patient was made aware, she was happy to go ahead, and as long as the tooth obviously has some cuspal coverage, the patient's going to get a little bit more time with this tooth than say, if we took the tooth out. Another thing to mention in this case is that when we look at the radiograph, the canals are quite sclerosed or calcified, specifically in the mesial root. And weirdly enough, this patient had a CBCT previously for a different issue, and the CBCT was a 5x5 image, and it'd been taken in such a way that it managed to get a little bit of this lower right 6 on the cone beam CT image. So on the 2D image, it doesn't look like it's the canal spaces are quite wide in the apical third, but when we look at the CBCT image here, you can see that there's clear canal space. It shows that also the distal has a double root coronally, but as it reaches the apical third, these two canals join, and it's kind of a bit ribbon shaped. And all of this information helps you plan for this root canal. Okay, so what I'm concerned about is joining or splitting canals. So I know that these two canals on the distal aspect join. It's just something that it just plays in the back of my mind to help me sort of plan and be just more efficient when we're doing this root canal. So we pick up the case when I have seen this patient for the second time. So during the consultation process, I removed the filling just to assess the crack, and then I dressed the tooth with non-setting calcium hydroxide. That is my intracanal medicament of choice at the moment. And again, you can see the crack here quite clearly. It's mesial, distal, and buccally. And when we dry it off, it kind of shows that these cracks don't extend too deep, and also is where you can't see the crack moving across the pulpal floor. So I'm relatively happy in that case. And again, first thing we do is we just fill the cavity with irrigant. And in the first instance, what I'm going to do is I'm going to try and negotiate down the mesiolingual canal. Usually I'd like to attempt to go down the distal because it's the easy one, but for some reason I'm just going to do it in the middle mesiolingual today. I'm using a size 8D finder, and I just can't seem to get down. What I'm not going to do is I'm not going to push this too far. I'm going to try try with the MB canal in the size 8D finder, and again, I'm just getting a little bit stuck. I'm getting into the sort of the coronal couple of millimeters, but I'm getting stuck. What I'm going to do is I'm just going to abandon trying to get down the mesial canals, and then I am going to go down the distal. I should have done that in the first place, and we negotiate quite easily down there, and we're going to use these MiniCut blackjack files just to open up the coronal third in this canal. And when we look down this canal orifice, we can see that there's obviously 2 canals, and I know that there are already 2 canals because we looked at the CBCT, and I'm just going to choose one canal. In this case, it's the MB. Feels like it's the longest, the straightest, and the easiest one to get down, and I'm just going to try and gain the working length here. And we reach the working length quite easily, so I'm going to go straight for our 1503 MiniCut file here. Again, this is used at quite a quick RPM, but it is super efficient at cutting. It gets straight down to length really nice and easily, and then we're going to do our final shaping with a HyFlex 25. And I'm using a hybrid system here. I really like the 1503 MiniCut, and again, I really like the HyFlex. I try my best to use different file systems, especially final shaping files, but I always get back to my HyFlex EDM. I feel like the cut efficiency great. I think the tape is just about right, and you know, if you really like a file, why change? You know, some people like reciproc, some people like Wave 1 Gold. In my case, I just always go back to my HyFlex 25 variable taper. And once the DB's been shaped to length, I'm just going to shape the distal canal, and it's the same protocol. I'm just going to use my 1503 MiniCut, give it a good old clean out, and then I'm going to use my HyFlex 25 variable. And if just to prove it even more, even though you've seen the CBCT images, when we aspirate and irrigate the canals, you can see that both of these canals aspirate and irrigate at the same time, which indicates that they are joined. So it's at this point we know that the distal canal is shaped, cleaned, and ready to rock and roll. We're now going to turn our attention back to the mesial canals, and sometimes it can be quite frustrating when you're trying to negotiate a canal, you're just not getting anywhere. And I think to sort of quell your frustrations, the best thing to do is just to move on to a different canal and then shape that, get that sorted out, and just go back to the canal with a fresh pair of eyes, if that makes any sense. And in this case, I'm just using a low energy ultrasonic just to slightly open up the canal space. You know, maybe I can't get down the canal because it's just getting caught further up, and I'm going to use a high energy ultrasonic just to give it a bit of a clean out. And you can see here now that the mesial canal orifices are just looking a little bit clearer. So at least we've boxed that off. We've sort of ticked that off. We know that that's not the problem. And then I'm just going to attempt to negotiate the mesial buccal canal with a size 6 C+ file, and these C+ files are a little bit stiffer, and I can just kind of feel the stop here. I'm just going to make a little bend in the end of this file, and I'm just going to move it around a little bit until we feel that kind of drop in, and you can see we've just dropped into the mesial buccal canal here. Worst thing to do now is to pull it out. Okay, I'm going to gain a working length with this size 6 C+ file, but I know that the working length is going to be a provisional one, and this is because using a hand filer which has a very small diameter doesn't give a very good working length measurement. But I just want to try and get some kind of provisional working length measurement just to know to see where I am. And again, when we have gained the working length, I'm just going to give it a little bit of a wiggle back and two just to make sure that this sort of negotiated canal with this file is patent. Don't pull it out straight away. You know, sometimes I'll say to my nurse, I'll put the apex locator on, she'll pick up the pen and she'll be waiting for me to give her the number, and I'll just say, hang on a sec, I'm just giving it a little wiggle. So it's really important not to pull it out straight away when you get to the working length. That's a really important thing to mention. And then once I've got the provisional working length with my size 6 C plus file, I am going to use a higher diameter K file. In this case, I'm going to use a size 10 just to get to confirm the working length. Again, there's a bit of a bone of contention between should I use a size 10 or a 15. I think in this case, the tooth is quite sclerosed, so I can't go up to a 15. The 15 arguably is going to get a better and more accurate reading, but in this case, I'm just going to use the size 10. Again, make a tiny little bend at the end, drop it past the ledge, gain the working length and give it a little bit of a wiggle. And once we know that the mesial canal is patent, I'm going to use a 1403 tooth saver file, and then it's the same protocol to length. We're going to use the 1503 MiniCut, and then we're going to use our size 25 HyFlex variable. You know, there is again another there's lots of arguments in endodontics, but I suppose something to mention here is that, you know, I've struggled to get to length with my size 6 file, and I suppose there's an argument to say going from a 15 glide path file straight up to a 25 variable HyFlex, maybe you're living quite dangerously there, and there is a strong risk of you ledging a tooth. And in fact, 2 days ago, I went from a 15 to a 25 in a premolar single rooted tooth, and I managed to slightly ledge the tooth because the diameter step up from a 15 to 25 is quite significant. So what I'm trying to say is that you know, there is an argument to say that it might be a better sort of protocol to go from a 15 to a 20 to a 25, and you know, going from a 15, 20 to 25, this ensures a smoother progression and it's less likely to ledge the tooth essentially. So the final canal to shape is the mesialingual, and again, this was the very first canal that I tried to get down and I just couldn't get anywhere near. So in this case, I'm going to use a size 8 D finder. I'm going to put a little bend at the end of this file, and you know, even walking this bended file in place is still coming up a little bit short. I can't quite get all the way to the end, which is incredibly frustrating. And what I'm going to do is I'm going to adjust the rubber stopper so I know how far I've got with the hand file. I'm going to place the 1802 tooth saver file to length off. Okay, I'm going to push it as far as it'll go, and then I will turn it on so it'll reciprocate, and then I'm going to sweep the file out. Okay, and I'm going to do that a few times, and then I'm going to then move over to my 1403 tooth saver file, and it's the same motion. I'm going to place it in off, and I'm going to turn the motor on and reciprocate and sweep out. And what you'll notice here is that it's ever so slightly slipping down to length. So once we've used these two files, we've reciprocated, we've sweeped it out, we're then going to use a size 6 C plus file again with a bended end. We're going to try and negotiate past the furthest point we got with the size 8. And what you'll notice here is that there's a little bit of movement, a little bit of watch winding, a little bit of turning around, and then what you feel is the drop here, which is again one of the best feelings in root canal. I always say this, but it just is genuinely one of the best feelings in root canal. And we're going to again do the same protocol we did with the mesial buccal canal. We're going to gain a kind of provisional working length so we know how far to go. And one thing you'll notice here is that when I place the C plus file in the canal, and don't forget the canal is full of irrigant, okay, and then I've put my apex locator on the file, but the file is quite far up. The apex locator screams 0, okay, and this is one of the problems that you have with having a cracked tooth, because don't forget the irrigant is going to flow into that crack on a microscopic level, and then that's going to create sort of the circuit for the working length. So you'll notice here that what I do is I have to suck some of the irrigant out of the cavity, just to ensure that we get a correct working length here. And we're going to step up again. Again, I don't want to do too a heavy step up, so I'm going to go to a size 8 definder. Again, I'm going to make a small bend at the end, and we're going to just move past that. Say we'll call it a ledge, and then give it a bit of a shape out, and then we're going to move up to our shaping file. So again, I'm going to go back with the 1802. I know that is a really nice transition. Despite you've got I've used an 8 to an 18, that is not the significant issue. The significant issue is the taper. So this 1802 in the reciprocation motion is now slipping quite nicely to length. And then again, it's just the same protocol as before. We're going to step up to the 1503. Again, this is quite a fast rotation motion. I believe it's about between 800 and 1000. We're going to shape it to length, and then we're going to recheck the working length of the size 10. So we have the provisional working length. The reason why I opened up the canal space before I got my confirmed working length is I just feel like I wanted to remove that ledge before I did anything else. And I suppose in a way it's just personal preference. It's just that inside me I just don't like a ledge in a tooth, and I just want to get rid of it as soon as possible. So we use the size 10K file just to confirm the working length, and then we're going to finish this canal again just with the same protocol. 1503 to length, 25 variable HyFlex, 0.5 millimeters away from the zero, and then we're ready for our cone fit radiograph. I have a look at the x-ray here, and it just looks really, really, really nice. These are the kind of x-rays that make you very, very excited, only because you've got two little flicks at the end here, and it just looks really, really nice. And I'm always saying that, but it just really, really does. And then it's just the same. If you've seen a lot of my videos, it's the same thing over and over again. We're using our final irrigation protocol. We are using sodium hypochlorite. We're gonna activate it. I'm using the 18th Ultra X on irrigant activator here, and then we're going to use 17% EDTA. We're going to activate that, and then I'm going to do a final rinse with my sodium hypochlorite. Again, activate that. And some people ask me, how much hypochlorite do I use? Well, I use enough hypochlorite so when I activate the irrigant, it doesn't sort of change colour at all. It stays clear. So that's when I know that I've irrigated the canals enough. And again, we've irrigated and cleaned, and we can see the crack here in all its glory. Okay, I know it's not pretty. I know it's not the best, but the patient's been consented. I'm happy. The tooth's going to get a crown on this tooth ASAP. So, I think sometimes in dentistry there are always compromises, aren't there? If the tooth was perfect, well then the tooth probably wouldn't have needed a root canal. So, and sometimes you speak to patients and they don't fancy it. And that's the whole point of the consenting process. So I think in this case, we know the prognosis is poorer than we say with a tooth without a crack. But in this case, the patient's made an informed decision and they're happy. And then we're just going to dry the canal with paper point. So we're ready to obturate now, and I'm using one fill, which again, if you've seen a lot of my videos, I like to use one fill. And you can see here when I place the one fill in the distal buccal canal, it fills both canals. But we knew that, didn't we? We knew that because on the CBCT it was joined and it aspirates and irrigates at the same time. And one thing I have started to do recently is I place the one fill to length, and then I use a file and I introduce the file at the working length. And the reason why I do this is because I feel like it pushes the one fill all the way to the apex, and it also reduces the risk of vapor lock. So sometimes when you put like a big globule of sealer into a canal, this can stop the GP going to length. So I just like to make sure that it is patent, if that's the right word. And again, I don't need to put any sealer in the distal lingual because that's filled up due to the pushing of the GP in the distal buccal canal. And then I'm just going to burn off the excess GP with my heated plugger. Again, I always say this, if you're not into endo but you fancy buying something, the first thing to buy is an Apex Locator. But the second thing to buy is a heated plugger. You know, when I first qualified, I used to use a Bunsen burner and an excavator, and we had this really like nasty sort of burner excavator, and it just makes a bit of a mess, and it also takes time to do that. You have to heat it up, and it's a bit of a pain. So you know, if you just bought a really cheap heated plugger, it just cuts out maybe 5 minutes of your time. And with things like this, it's all about cutting out those little tiny things that makes the the treatment more efficient. And here I'm just using a Mach 2 plugger just to condense it down. And then it's the same protocol for the mesial. I'm going to fill it with one fill using these visco tips here. I'm going to use a file. It can be any file at all, just to kind of push into that canal, just to open up, make sure it's patent. And I'm going to push the GP to length very gently. There is a little bit of flick at the end, so what I don't want to do is I don't want to push the GP down really strongly, because that sort of bend at the end can sort of concertina, and then it'll just look awful, and also it's not filled either. And we look at the post-op radiograph, and it just looks really nice. These when we get cases like this, it's the thrill of the fill, isn't it? So we can see on the distal, we've got a nice flick at the end, and you'll notice actually with distal canals is that there is usually like a kind of a distal sort of quite an acute bend at the end of the canal, and this can sometimes be a challenge when you are shaping your canal. So if you're doing a lower 6 and you're getting a bit stuck at the end, and you're thinking to yourself, what's going on here? It's usually because on the distal there's this really acute bend. So that's just something to be mindful of. We look at the mesial canal. Again, we've got this little flick, but also we've got this lateral canal, which again, when we look at the end of this mesial canal, you can see that maybe there's quite a significant radiolucency, and the radiolucencies, you can kind of draw like kind of a circle around them, and you can kind of see now that there's 2 portals of exit. And the great thing about this is I've filled those 2 portals of exit, and this is going to increase the prognosis of the tooth over a long period of time. And the last thing I'm going to do here, arguably should have been the first thing I did, and this is I'm going to reduce the height of this tooth. I know that I follow quite a few other endodontists on Instagram or TikTok or YouTube, and they like to reduce the height of teeth, all teeth, because they know that this tooth will eventually have a crown on it. And the great thing about reducing teeth is that it creates a really nice stop for your for working length measurement. And there's an argument to say maybe I should have done this right at the start, but I didn't anyway. So what I'm going to do here is I'm going to reduce the height of this tooth completely. I'm going to take it completely out of occlusion, and this is going to make sure that between now and when the patient sees the dentist for the crown, the tooth isn't having too much pressure put on it. And of course, it's not going to completely get rid of all of the pressure, because obviously the patient's going to chew down there. Despite me saying it's got a crack, they'll forget. They'll be out and they'll be eating on this. And I'm making a bit of a mess of this because I'm touching the rubber dam, but it's getting the job done. And we give it, once you've reduced it, you've got to take the sort of sharp edges out. And then when we look intraorally now, when the patient brings their teeth together, you can see that this lower right 6 now is completely out of occlusion. I mean, it looks like the upper right 4 is touching it, but if you move the microscope around, you can see that it is all completely out of occlusion. And we do say to patients on occasion, teeth need to be crowned straight away. I say to the patient, you need the teeth crowning straight away. And you can never really know when the tooth is actually going to be crowned. And that could be a few reasons. It could be obviously cost, could be the patient's going away, could be, the dentist is away. So we're going to make sure that this tooth is out of the occlusion, and it's not going to be bit on, because we don't know when the tooth's going to be crowned. You know, could be next week, could be 6 months. And that is it. Again, this has been a really nice video. There's been lots of learning points, lots of I'm starting to use a different protocol for a few things, and it's nice to showcase that. And I suppose in a way it's like just to say is that, you know, you might have been doing root canals for years and years and years, and you still change your practice. You always listen to other people. You know, one of the great things about this this channel is that patient is that dentists point things out, and I think it's fantastic. You know, I've obviously got a blind spot with things, and it's great for dentists to comment below. So on that note, if you have watched this video and you've seen something glaring of the obvious that needs to be sorted, and if you see something glaringly obvious what I've missed, or you would have done something completely different, don't be scared. Don't be scared to type in the comment section below and let me know. And you know, all of your messages of support are always great. If you want to support the channel even more, we've got a membership program. The membership program obviously supports the channel, keeps me independent, keeps my voice independent. But also, if you join the membership program, you get early access to content. And also, if you've got a certain tier of membership, if you ask a question in the comment section below, I will answer you with a video short. And overall, thanks for watching, and please like and subscribe, and I'll see you in the next video. Bye bye.